Tissue repair, clinical meditation. Close your eyes, take a slow breath in, and slowly breathe out. Imagine that you are a doctor, but now, instead of standing outside the patient, you are traveling inside the patient's body. You enter through the bloodstream and arrive at a small wound in the skin. You can see the normal epithelium, a neat row of cells, everything intact, everything organized, and then injury. A small superficial injury removes some epithelial cells. You watch carefully. The body has two possible strategies. You hear the body whisper, "Can I replace what was lost?" If the surviving cells and stem cells can restore the tissue, the body chooses regeneration. But if the injury is severe, if the supporting connective tissue scaffold is destroyed, the body chooses scar formation. Remember this image. Mild injury leads to regeneration. Severe injury / scaffold damage leads to scar. Now enter the regeneration zone. You enter the injured tissue. The surviving cells are beginning to divide. Growth factors are calling them. You hear, divide, divide, restore the tissue. You see three important groups of cells responding. 1. Surviving tissue cells. They proliferate and try to restore the original architecture. 2. Endothelial cells. They begin preparing new blood vessels, because repairing tissue needs nutrients and oxygen. 3. Fibroblasts. They move toward the injured area, ready to produce connective tissue if regeneration cannot completely repair the defect. And remember, growth factors plus ECM equals signals for proliferation. The cells are not working alone. They are touching the extracellular matrix through integrins, and the ECM is giving them instructions too. Now look at the three types of tissues. Imagine 3 patients standing before you. Patient 1, lobile tissue. His cells are constantly being lost and replaced. Bone marrow cells, skin epithelium, oral cavity, esophagus, vagina, cervix, GI tract, urinary transitional epithelium. These cells are continuously dividing. If their stem cell pool survives, they can regenerate readily. Patient 2, stable tissue. Now walk into the liver. The cells are quiet. They are sitting in G0, not actively dividing. But suddenly, injury occurs. The cells awaken. We can divide when needed. Liver, kidney, pancreas, endothelial cells, fibroblasts, smooth muscle cells. These are stable tissues. They normally rest, but injury can push them back into proliferation. And remember the special liver, because the liver is exceptionally good at regeneration. Patient 3, permanent tissue. Now enter the brain. You see neurons. They are terminally differentiated. They do not readily proliferate after birth. You move to the heart. You see cardiac muscle cells. Again, very limited regenerative ability. So when severe injury destroys these tissues, the body cannot simply recreate the lost cells. Instead, scar formation dominates. And skeletal muscle? You see special cells attached to the endomysial sheath, satellite cells. They provide skeletal muscle with some regenerative capacity. Now enter the stem cell niche. Imagine a tiny protected room. This is the stem cell niche. The stem cells are waiting quietly. Injury sends a signal. The door opens. The stem cells begin proliferation to differentiation to mature cells. They move toward the injured tissue and repopulate it. Their importance becomes greatest when the surviving differentiated cells themselves have little or no proliferative capacity. Now enter the liver. You are standing inside a liver after a partial hepatectomy. a large part of the liver has been removed, but the remaining hepatocytes look at the empty space and begin multiplying. In humans, the liver can regenerate up to about 90% through proliferation of residual hepatocytes, but the hepatocytes need to be prepared first. You see the Kupffer cells. They release IL-6. IL-6 tells hepatocytes, wake up, become competent to respond to growth factors. Then you see the growth factors arrive, HGF, hepatocyte growth factor, and TGF-alpha. They act on the primed hepatocytes and stimulate proliferation. The liver grows back. Now imagine a different patient. This patient has chronic liver injury and inflammation. The hepatocytes are no longer able to proliferate adequately. So another door opens, stem cells. You travel into a structure called canal of Herring. You see bile canaliculi joining larger bile ducts. Here, liver stem cells can contribute to repopulation. So remember your liver story. Partial hepatectomy leads to surviving hepatocytes. Proliferate. Chronic injury/inflammation with impaired hepatocyte proliferation leads to stem cells. Contribute. Now the wound is too severe. You return to your skin patient. This time, the injury is deep. The supporting connective tissue scaffold has been destroyed. Regeneration alone cannot restore the architecture. The body says, I cannot perfectly rebuild this, so I will patch it. And that patch is scar. Fibroblasts will eventually deposit collagen. The tissue may function, but it will not be exactly normal. Think regeneration equals restore. Scar equals patch. Step 1, hemostasis. Immediately after injury, blood begins escaping, but within minutes, platelets gather. They form a hemostatic plug. You see the plug sealing the wound. It stops bleeding and provides a scaffold for the formation of a stable clot. The emergency bleeding phase is controlled. Now repair can begin. Step 2, inflammation. Look at the wound again. The first responders arrive, neutrophils. You see them entering during approximately the first 6 to 48 hours. Their mission, eliminate offending agents, clear debris. Then, monocytes arrive. They enter the tissue and become macrophages. As offending agents and necrotic cells are cleared, the inflammation begins to resolve. Step 3, cell proliferation. Now, the wound is clean enough to rebuild. Several cell populations enter. You see epithelial cells. They receive local growth factor signals and migrate across the wound. Their mission, cover the wound. You look deeper. Endothelial cells. They begin proliferating and forming new blood vessels. This process is angiogenesis. Then you see fibroblasts. They proliferate, migrate into the wound, and begin laying down collagen. This collagen will eventually become the scar. Step 4, granulation tissue. Now look at the wound. It has become pink, soft, and granular. This is granulation tissue. Don't confuse it with granuloma. Inside this granulation tissue, you see proliferating fibroblasts, delicate new capillaries, loose ECM, and mainly macrophages. The amount of granulation tissue depends on size of the tissue defect and intensity of inflammation. The wound is progressively being filled. Meet the macrophage, the repair director. Now imagine one macrophage standing in the middle of the wound. It is the central coordinator of repair. First, it clears offending agents. Then, it clears dead tissue. Then, it releases growth factors. Then, it releases cytokines. These stimulate fibroblast proliferation, connective tissue synthesis, and connective tissue deposition. You notice something important. The macrophage has changed its personality. During inflammation, you mainly see M1, macrophages. Their job, defense, kill microbes, clear dead tissue. But during repair, M2, macrophages become predominant. Their job, repair, terminate inflammation, and induce tissue repair. Now, angiogenesis. This is the final grand scene. The wound desperately needs blood. Imagine the old blood vessel beside the wound. It is quiet. Then the body announces, angiogenic switch on. The major promoters appear, VEGF, FGF2, PDGF, angiopoietin, and inhibitors such as thrombospondin, angiostatin, endostatin. The balance shifts toward growth. Step 1, vasodilation. The existing vessel dilates. Think NO plus VEGF leads to vasodilation/increased permeability. The vessel opens toward the injured area. Step 2, parasite separation. The parasites detach from the abluminal surface. The vessel is now ready to sprout. Step 3, basement membrane breakdown. The basement membrane is degraded. You see a pathway opening. The endothelial cells can now escape. Step 4, endothelial migration. Endothelial cells begin moving toward the injured tissue. One cell takes the lead, the tip cell. Behind it, the stalk cells follow. Step 5, endothelial proliferation. Endothelial cells proliferate just behind the leading tip. The stalk becomes longer. The new vessel begins extending toward the wound. Step 6, capillary tube formation. The endothelial cells remodel themselves and form a capillary tube. A tiny new vessel is taking shape. Step 7, periendothelial cell recruitment. Now the vessel needs support. For small capillaries, parasites are recruited. For larger vessels, smooth muscle cells are recruited. The vessel becomes mature. Step 8, stop. Finally, endothelial proliferation and migration are suppressed. The basement membrane is deposited. The new vessel stabilizes. You look at the wound. What was once a damaged, bleeding space now contains new epithelium, new blood vessels, fibroblasts, collagen, granulation tissue, and finally, a stable fiber scar. Final 30-second visual. Before opening your eyes, see the entire movie once. Injury down. Can regenerate? Yes. Arrow regeneration. No arrow scar. Arrow hemostasis. Platelet plug arrow. Inflammation. Neutrophils arrow. Monocytes/macrophages. Arrow proliferation. Epithelial cells. Leads to cover wound. Endothelial cells. Leads to angiogenesis. Fibroblasts. Leads to collagen decreases. Granulation tissue. New capillaries. Plus fibroblasts. Plus loose ECM. Plus macrophages. Decreases collagen deposition. Leads to stable fibrous scar. And inside that story, remember the special branches. Labile leads to continuously divide. Stable leads to G0, but can divide after injury. Permanent leads to little/no regeneration. Liver, exceptional regeneration. M2, macrophage. Repair, VEGF. Angiogenesis, angiogenesis. Dilate, detach, degrade, migrate, proliferate. Form tube, recruit support, stabilize. Take one final slow breath and let the entire wound heal in your imagination.